Hello friends, today I will be discussing with you a very important topic of optimizing medical management of heart failure in type 2 diabetes, mainly in diabetes mellitus, but we will be discussing most of the things keeping in perspective the type 2 diabetes, which is the major component of all our patients in our clinical practice. So this was actually delivered by me in recently concluded RSSDI 2021 hybrid conference, which happened in Ahmedabad, and most medical therapy, medical management of heart failure. Disclaimers: as far as disclaimers are concerned, there are none for this particular talk. There are no sponsorships and nothing being company oriented or guided by any company. So when it comes to CKD, heart failure, and type 2 diabetes, we know that all these three are interrelated and there is a cross overlap and bidirectional relationship amongst these three. Whenever there is one of them is present, the other two can soon be reaching or soon be joining it, because there is 40 to 30% overlap in most of the cases when one of the three is diagnosed. This is a very well known fact. Most of the times the other components may remain hidden, but we do know that heart failure and CKD are two important components of complications of diabetes, which are always lingering in the background in every diabetic patient, and most of the times they are not diagnosed. They make the cardiorenal complication burden really costly, really fatal, really disastrous. But unfortunately, no physician, right in the beginning when he starts therapy, tries to focus on these two ailments. So, if we bring out certain therapeutic changes or certain strategic changes, which unknowingly, just by default, can control these two ailments which are there in the background undiagnosed and not being actually looked after by the physician also, that particular strategy will definitely be of great help to the community, to every patient of diabetes. Let us try to see and let us try to explore how that can be done. Now, serendipity introduced us to this class of molecules. Now we have five of them, and it was 2015 when EMPA-REG trial came out with flying colors, and everyone took notice of what was happening with the cardiorenal complications in diabetic. Out of the blue, we had very robust, very powerful data which told the how cardiovascular morbidity, mortality, including hospitalization from heart failure, can be prevented by just with introduction of one molecule in your therapeutics. This was absolutely hitherto unknown, and till that point, no anti-diabetic drug was having such powerful impact on cardiovascular complications. And I must say, this was a game changer. This was the first class which actually reduced the which actually changed the natural course of the disease of diabetes, what we clinician knew at that time. And after almost 1 lakh patient data, more than 650, 700 publications, I must congratulate my medical fraternity. We are delighted to have now 85 to almost 100 changes, tweaks, rephrasing of guidelines, and introduction of new guidelines being based on these particular class of drugs and how they should be included in your therapeutics. This is indeed has changed the face of diabetes treatment across the planet. So much is the level of excitement and jubilation that principles and pathophysiological targets of heart failure with reduced ejection fraction pharmacotherapy have been designed, have been defined now. Now, in one slide, so impressively, wherein the cardiologists are now telling you that there are five important pathways angiotensin 2, norepinephrine, aldosterone, neprilysin, SGLT2, and how these five pathways can easily be, uh, not easily, I must say, can be effectively controlled or tamed by these four drug classes: ARNI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And then they have three other drug classes to help them: ivabradine for heart rate management, and hydralazine and nitrates in certain population classes. And of course, now with Victoria trial, they have vericiguat, a guanylyl receptor modulator, and the therapeutics is pretty robust and strong now with cardiologists, and the level of jubilation and level of conviction continues, and the new guidelines being defined from Europe now clearly show that these are the four pillars of heart failure with reduced ejection fraction therapy, that is RAS inhibitor or ARNI, and beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. And of course, for getting rid of salt, water, and congestion, there is always availability of loop diuretic has always been with us. So all of these four pillars, you can say, have one A recommendation for heart failure with reduced ejection fraction management. So much so that the sequential introduction of one after the other therapy has no more being recommended now. The cardiologists have realized that all those four pathways which are being tackled by these drug classes are actually working simultaneously in every patient, and there is no such thing as a stable heart failure. Whenever the patient is clinically in a stable state, actually the heart is facing the inflammatory onslaught all from all over the surroundings, and all these four pathways are simultaneously active in every heart, against every heart. Therefore all the therapies must be included right from day one, as soon as the HErEF is diagnosed. And they say now that even in the stable phase, you should include beta blocker, SGLT2 inhibitor immediately in every diabetic patient, and soon ARNI and MRAs should be following there with optimal doses. That is the most important catch here. Full doses are to be given, the evidence-based doses are to be given. So GDMT sequencing, that is the guideline dependent medical therapy, being sequenced over 2 to 4 weeks, then 2 to 4 weeks titrating upwards, is waste of time. Has been, sorry for the spelling there, is waste of time, has been very well recognized and agreed upon by the cardiology community, because this will take not less than 28 to 56 weeks if you start everything sequentially, and the effect of these drugs appears so rapidly, because SGLT2 inhibitors start working in 2 to 3 weeks, and most of the drugs, when if included in say within 20 to 40 days, the efficacy of these drugs is so great that heart failure risk alteration and hospitalization reduction starts within 2 to 3 weeks of the inclusion of every drug class. Each one of them is so efficacious. So rapid sequence and simultaneous strategy is now being recommended right in the beginning from day 1, day 7 to 14, day 14 to 28, day 21 to 48. You can have clearly an idea how fast they are now recommending the therapies, so that sooner than later, every heart failure HErEF patient is receiving all the four drug classes. The rapid improvement in health status, rapid reduction in heart failure hospitalization, rapid reduction in mortality, rapid improvement in ejection fractions, rapid reduction in rehospitalization, and improved use and adherence, persistence, and overcoming inertia, or the advantages and use of optimal doses right from the very beginning, as another advantage which I would like to add to this slide. So with rapid sequencing, without wasting time in sequencing, or simultaneous strategy will give you all these benefits right from the day one, the moment you have included all the four therapies. But with the HErEF reduction, the heart failure with reduced ejection fraction, All these things happening, the good things happening to the patient and cardiology community are welcome steps in medical therapeutics. Nobody should disagree on that. But as a diabetologist working in primary and secondary care like you and me, I would like to ask a question. Who is the most delighted physician or patient in this development? Not much for us is there in primary and secondary care to be practiced out of all these four therapies in HErEF. We are not worried much about HErEF also. The central damaged organs of the heart is not repaired. It is being just helped by the tackling of the neurohumoral pathways by these drug therapies. And we are just improving hospitalization from heart failure. Not much is being done against the mortality related to heart failure. So the delighted people are those who are saving money out of these strategies, like states exchequer is being saved, insurance money is being saved, hospitalizations are saved, hospitals are less burdened, and of course pharma people are happy. They are having now a clear-cut guideline indicating which drugs to be used. But for primary and secondary care physician, few other things of great worry, they remain in the background. And these are, let us start with this another set of slides which will be telling you why we as diabetologists in primary and secondary care must be worried about other things also. So we have clearly seen, starting from the data being collected from early 2000 onwards, that every year it is the HErEF, the heart failure with preserved ejection fraction, that is phenomenally increasing by every passing year, and we are indeed worried about. And we know that 50 to 60% of the contribution to the HErEF increase is coming from the diabetes. We also know that once HErEF is diagnosed, or any heart failure is diagnosed, or symptomatic heart failure, once it is diagnosed in diabetic, the survival rates are markedly going down after that day. And after that, actually, the mortality is guided by the heart failure and not by the diabetes. It is so serious a condition. We diabetologists very clearly know that every 1% increase of HbA1c leads to 13% additional risk of heart failure in every diabetic patient. And the moment the HbA1c crosses 10%, the risk of uh, heart failure increases by 66%. And as soon as albuminuria is added to the patient's condition, the CHF hospitalization rates will be 3 to 4 times. The moment a small complication adds up, a microvascular complication adds up to the heart failure background in a patient, the hospitalization is 3 to 4 times. Other important thing which every clinician like you and me who are working in community treating our patients on in OPDs, we must keep in mind that there are stages of heart failure, stage A, B, C, and D. And we know that the moment diabetes is diagnosed in a patient, especially if he's hypertension or hypertensive or having metabolic syndrome, also the moment the diabetes is diagnosed, his heart is in stage A of heart failure already. Whether there is any symptom, sign, or structural heart disease present or absent, whatever, nothing, just clinical diagnosis of diabetes with hypertension or even without hypertension, if it is done in a patient, the heart of that patient is in stage A of heart failure. When stage A and B, when the structural heart disease is documented and easily detectable in a patient, the patient is in stage B. Till this point, no symptoms have appeared. And any early, decisive, reliable, feasible prevention strategy has to be operative at this stage from the date of diagnosis and onwards. If stage A and B are prevented, we will be able to save our patients from reaching the stage C. And when we are doing something at this stage, we have to act against all these uh, uh, all these adverse conditions which are there in the circulation in the milieu of the diabetic patient, which are increasing the damage being caused to the cardiomyocytes and the heart as a pump and heart as a muscle, and each cardiomyocyte is then facing a danger, or I must say, the threat of decreased perfusion from coronary artery disease, fibrotic changes, and ultimately leading to diastolic and systolic dysfunction, which leads to heart failure. Needless to say that oxidative stress and inflammation, all these are always associated with the atherosclerotic and hypertensive milieu in a diabetic. So heart perfectly is normal in the beginning when the diabetes is diagnosed. It is the surrounding around whatever is happening around the normal heart lying there in the body are slowly and definitely killing that performance of the myocardium, which was healthy till the point that diabetes was diagnosed. When we think of prognostic implications of symptoms, this is a very serious slide. Just take care to see that the moment stage A and B is passed and the patient becomes symptomatic, you can see that how the survival rates rapidly go down. So if the patient becomes symptomatic, we will have to be very, very aggressive. Still, we will not be able to save this patient from early mortality. The life years have been cut and mortality date has been already, you can say, decided. So acting at a stage A and B is very important. Getting symptoms and then diagnosing heart failure is pretty late. We are already late. And this is the reason why I said in one of my previous lectures also, this is the reason that when we define heart failure as a condition where the heart is not able to pump appropriate quantities of blood as required by the body, that definition is actually must be revised and not fit for clinical usage, because we are already late when that thing is happening. Then not much is remaining after that as far as the treatment is concerned. As clinicians, as diabetologists, we also know that heart failure with preserved ejection fraction and heart failure with reserved ejection fraction, observational studies suggest that clinical outcomes are pretty similar, and time to death is, you can say, is matching in both the conditions. So what matters for a responsible clinician like you and me, we have to see that irrespective of ejection fractions, we should be able to pick up those patients who can be classified as heart failure with preserved ejection fraction. And for that, we must have a solid definition. First of all, let us see what has been done in that direction, because we know that therapies which are successful for HErEF have not demonstrated much, promise in heart HFpEF treatment. Now, let us consider these two particular classes of drug. We can clearly see that there is a whole lot of trials with the CVOT trials which have been done with SGLT2 inhibitors and GLP-1 receptor analogs. And you can clearly see that when it comes to MACE reduction, we have GLP-1 analogs showing great promise. And when it comes to cardiorenal protection, nothing can beat SGLT2 inhibitors. When we think of only MACE reduction with GLP-1 analogs, we must keep in mind that 50% of the contribution, almost 35 to 50% of the contribution to the heart failure in diabetics is coming from the ischemic causes, which are always in the background. So atherosclerotic cardiovascular disease is always there in the background, should not be forgotten. A big reform is therefore required. Every diabetologist must be trained to look for the heart failure in diagnosing the heart failure and treating the heart failure. When it's not, we know that it is not just MACE. Heart failure was causing substantial damage, as was proved from that out of the blue data which came with EMPA-REG outcome. Till that point, we were not concentrating on heart failure at all. So diagnosis of heart failure in diabetics is missed or markedly delayed if there are no protocol recommendations, there are no compulsions for diabetologists also to look for the heart failure. And we don't have equipment and we have no training, formal training in cardiology as far as the primary, secondary care physicians are concerned. And there are no treatment guidelines, to diagnose incipient or subclinical cases, and there are no approved treatment protocols of heart failure with preserved ejection fraction also. Clinical inertia therefore starts right in the beginning when we start treating hyperglycemia in our prescription. So the moment we start counseling and prescribing drugs for diabetes, heart failure is never in the background. Even we don't even think of heart failure when we are prescribing. So choice of drugs can make a difference. We know, we have seen this with GLP-1 receptor analogs and SGLT2 inhibitors. Can we break that barrier with the usage of these two drugs? Let us try to focus on that now. And with these two trials and the data available, as I told you, 1 lakh patient data, 700 publications, uh, organizations are so thrilled that they have actually changed the guidelines. The European Society now says why metformin at all should be used in drug naive patient in the beginning. Why not start with SGLT2 inhibitor or GLP-1 analog? And American Diabetes Association has also agreed that after metformin, the first thing, if you think of adding to the therapy, you should think of adding to the therapy is if the presence of atherosclerotic cardiovascular disease, then GLP-1 analogs, and if there are risk factors for CKD or there are cardiorenal risk factors in terms of heart failure propagation, then you should always think of SGLT2 inhibitors. Either or, any one of these two should be accompanying metformin right in the beginnings. That is the great change which has happened to the therapeutic strategies being recommended by the consensus reports or by the guideline algorithms. We know that CV stratification and treatment recommendations which are being done by European Society right now clearly show that every diabetic is a moderate risk patient. There is nothing like, there is no patient who can be classified as low risk. And most of the high risk and very high risk patients should be considered for one of these two therapies which have shown enormous benefit and enormous promise in cardiovascular risk reduction and cardiorenal risk reduction. With this background, let us now focus on what the cardiology community has done. That was one type of precision medicine. I must tell you, the moment you start selecting patients and selecting drug for that particular type of patient, this is, you can say, the precision medicine step one we have already taken. And when we come to the how to define heart failure now in this new era of the new drugs being available, so that we can make fullest use of these drugs as early as possible. That is the reason, if you want to standardize a particular therapy across the globe with across the different communities of physicians working in different countries and different geographic areas, you have to have a universal definition for the first prerequisite requirement, the first prerequisite. So when it comes to precision medicine step 2, you can see that now the heart failure has been defined like this. This remains a clinical syndrome consisting of cardinal symptoms of breathlessness, ankle swelling, fatigue that may be accompanied by signs elevated jugular venous pulse, pulmonary crackles, peripheral edema, or due to structural and functional abnormality of heart that results in elevated intracardiac pressures or inadequate cardiac output. For the diagnosis, therefore, you have to have symptoms plus signs for all the three heart failures: reduced ejection fraction, mid-range is now called as mildly reduced ejection fraction, and preserved ejection fraction. So you can see that if the ejection fraction is less than 40%, 41 to 49% becomes mildly reduced, and more than 50% remains preserved ejection fraction. And focus on this particular area, being a diabetologist in primary and secondary care, we have to have objective evidence of cardiac structural and or functional abnormality consistent with the presence of LV diastolic dysfunction or raised LV filling pressure, including raised natriuretic peptides. The moment any chamber of the myocardium is stressed and stretched, there is a rise in natriuretic peptides. So natriuretic peptides have been now included to ease out a clinician when it comes to diagnosis of heart failure. This is a big change which has been welcomed by all across the world. The term mildly reduced has been used, and elevated natriuretic peptides uh, uh, evident of structural heart disease, if they are already diagnosed, is not mandatory. You should also keep in mind also. So based on evidence, this patient with mildly reduced ejection fraction may also benefit from therapies which are given to reduced ejection fraction. There is enough evidence of uh, this fact also. So when it comes to stages of A, B, C, D of heart failure, they have been now defined as at risk for heart failure, pre-heart failure being used for stage B, and heart failure stage C, and of course advanced heart failure is being used for stage D. All other things in stage A, stage B, C, and D are same as I told you in the previous slide. So continuing with the part 2, where to find out these patients, how to screen out high risk patients who will be where you can apply the new definition of the heart failure as I told you in the previous slide. Prediction of heart failure in type 2 diabetes. Predominantly, we are now here talking of heart PEF, that is heart failure with preserved ejection fraction. So in your clinical practice, this will be a step again towards a precision medicine, wherein you will be applying specific, precise therapies to the precise patient groups. And to find out those diabetics who are at risk of HFpEF, as I told you from the day one, the patient is diagnosed as diabetic, his heart is in stage A of heart failure, you can say, with the new definition, at risk, we call it. But then more than at risk can be found when you segregate the patients on these lines. And these are patients who are on insulin, sulfonylureas, oral antidiabetics like DPP-4 and triazolidinediones, TZDs, long duration of diabetes, more than 10 years of diabetes, and those who are having uncontrolled diabetes, all the time keeping their blood, these HbA1c levels beyond 7% or higher, and those who are having microvascular disease. These are very specific risk factors. Then cardiovascular risk factors like hypertension, obesity, and atrial fibrillation, all three are strong predictors of presence of heart failure in the patient. And then increasing age, patients who are having diabetes since, for example, 30 years or 35 years, and now they are 50 years, 55 years, again, you can find that increasing age is a risk factor. And obstructive sleep apnea usually forgotten. A history of troublesome snoring given by the spouses should be taken up very seriously. And all these patients should be now considered as high risk for HFpEF and try to find out if the HFpEF is actually present. And most interestingly, the new definition now tells you to go for anti-pro-BNP investigation test done, the blood test which classifies the patient in three different categories: less than 50 of anti-pro-BNP level, where you can continue monitoring the patient every 6 months or every year after that. But then 50 to 124 is the new group which has been recommended for immediate SGLT2 therapy inclusion in them. So 50 is the upper cutoff limit where SGLT2 therapy can be immediately added to the existing therapy, however good control the patient is maintaining. Irrespective of that, add SGLT2 inhibitor therapy to that particular patient. Previously, more than 125 was always considered as high risk, but definitely now 50 onwards, 50 to 124 and more than 124. And we know that of course these investigations like electrocardiograph to look for the cardiac size and cardiac silhouette, the contours of the different heart borders as defined by radiological criteria, whether they are normal or crossing the normal limits, all has to be done, no doubt, when we are now will be having app based and mobile based probes, eco probes also, which will soon be available in every clinic, but these are not going to be cheaper anyway. But then personal history and diagnostic testing routinely, which we are doing definitely remains there. It has to be done, but NT-proBNP is now further added to our armamentarium of testing for the detection of high-risk patients. Soon we will be having lots of predictor apps, and these apps will be available in our phones, on our smartphones also very soon, because companies are very aggressively working, especially supports of pharma companies is too much of their insurance companies are supporting these apps, wherein we can easily and uh, as early as possible can detect the patients who are having HErEF, so that the initiation of therapies can be done in time. So key point for the GP is we have to diagnose these patients, and NT-proBNP recommendations are class 1B level. So this is a very strong recommendation. Comorbidities, sorry for the typo again, comorbidities like hypertension, diabetes, hyperlipidemia, obesity, anemia, atrial fibrillation, COPD, any valvular heart disease, thyroid disorders, kidney dysfunction, whether diabetic or non-diabetic, or presence of stroke, cancers, any type of malignancy, treated or partially, or being treated or being cured also has to be kept in mind, because all these things are indicators of worsening uh, uh, capabilities for heart failure with preserved ejection fraction. They all can worsen, they all can precipitate, exacerbate, and presence of depression and infection, of course, we all know. So most importantly, anemia, obesity, hypertension, coronary artery disease, atrial fibrillation, diabetes mellitus, COPD, and obstructive sleep apnea are very important components, where we have enormous number of papers and peer-reviewed, validated papers which tell you that you will be getting dividends when all these are treated in your patients of FPEF, in terms of prolonging their lives and improving their quality of life and improving their survival. So we must not also forget, when it comes to anemia treatment, hematocrit increase with empagliflozin was reported right from the first trial, and this was confirmed by other STL with other SGLT2 inhibitors also, wherein erythropoietin levels were shown to be increasing, and performance of um, bone marrow towards improving anemia gets to be seen to be improved. And I distinctly remember Darren McGuire in one of his webinars told that the benefits are as great as 1 unit of blood doping being done by the athletes before marathon runners. And this Bernard Zinman used that almost half of the benefits can be ascribed to hematocrit increment in again one of his webinars. You may not agree to Bernard Zinman that half of the benefits are there because of this single attribute of this molecule, these molecules, but then substantial improvement is seen in hematocrit, no doubt about that. When it comes to hypertension treatment, we all know the real bang for the buck, as they say, actually lies with the improvement of the heart failure risk and heart failure as such with the treatment of hypertension. And we must not forget all those sorts which we should be using in hypertensive therapies, and they have already shown their powers to help in heart failure as such, because chlorthalidone in all head trial and spironolactone in top cat trial are established molecules, wherein they have shown their powers with heart failure treatment also. And recently finerenone in Fidelio DKD trial has shown results as good as credence. I distinctly remember again George Bakri's in one webinar telling that if you put the forest plots of Fidelio DKD trial parallel with the credence trial on the screen, you will find the cardiorenal benefits actually being replicated in Fidelio DKD trial as close to as it was seen in credence trial. And sprint trial, which is so celebrated in hypertension trial, we know it was in non-diabetics, but then in the sprint trial, the main data, the main robust P values were actually driven by heart failure reduction. So reduction of heart failure risk and improvement in heart failure risk with hypertension treatment has been validated in number of papers and stays there beyond doubt. Heart failure and obesity and improvement of all the components of uh, insulin resistance syndrome and inflammation, etc., have been again validated by different research and epidemiological and as well as the clinical trials also. And we must not forget that diet, exercise, and improvement of heart failure, preserve ejection fraction, quality of life, and walking distance, etc., has been reported in many papers and in published in peer-reviewed journals. And as I told you, every kilogram lost by any means improve everything related to inflammation and oxidative stress, including quality of life related to obesity and insulin resistance syndrome. And when it comes to GLP-1 analogs, again, this class is also maintaining the tempo of surprising us with trial after trial, and now cagrilintide, semaglutide is approaching close to the bariatric surgery results, and very soon I think bariatric surgeons will be out from the business of obesity management, because results of as high as 22% weight reductions with injectable therapies is being achieved with the sensible use and combination of GLP-1 receptor analogs with amylin, with glucagon inhibitors, etc. So the other important point which I would like to highlight for every clinician is not to forget that optimum doses must be used in heart failure management. Or patients who are at risk of heart failure, try to push in the medication to the maximal doses which has been shown to be beneficial for heart failure. And for example, in metoprolol, we can go up to 200 milligrams, and with ramipril, we can easily go up to 10 milligrams. We should not easily go. We should be going to the 10 milligrams. That has to be kept in mind, because we are using subclinical doses most of the times. Even in heart failure prescriptions, I have seen 100 milligram is the top dose of metoprolol being prescribed by most of the physicians, which is absolutely unacceptable. So this chart has to be kept in mind and should be kept on your clinic's OPD table, wherein you can easily have a look when you are prescribing and up titrating the doses, and try to go with the top dose which has been shown efficacious in evidence-based trial. Other important thing for a diabetologist is, when we manage diabetes, we have to manage hyperglycemia. So without hyperglycemia management, you cannot think that you are managing diabetes. But we know that when it comes to reduction of risk factors, including HbA1c, the heart failure risk is definitely not improving, as other things related to MACE, stroke, etc. are reduced. This is a well-known fact, and this has always been a frustrating experience in every diabetologist's life. So keeping this thing in mind, that heart failure risk is not declining, we have to now make choices of medicines very carefully from the available chart with us for the diabetes management. And you can clearly see from this particular chart, if you have a close look on it, keeping in view the negative attributes of each of the classes of the drugs towards fluid retention, hypoglycemia, weight gain, CKD, etc., you will find that GLP-1 receptor agonists and the SGLT2 inhibitors are the two classes which stand distinctly superior to every other class, and this I will call as precision medicine step 4. Now, applying precise choices to every diabetic we are treating in our clinics. Here is the forest plot which clearly shows the superiority of these two classes in terms of heart failure effects available as additional attributes additional to glycemic management with these two classes. And this particular class of SGLT2 inhibitors continues again to surprise us trial after trial after trial. And this Emperor Preserved trial, which was presented in European conference this year, has clearly shown new dimensions being reached by this empagliflozin, the celebrated SGLT2 inhibitor, which started the wind of change in diabetes management. And this has produced from 18th day onwards, the results were positive in heart failure with preserved ejection fraction, and the results were so impressive that 21% relative risk reduction was seen in hospitalization from heart failure, number needed to treat only 31, and absolute risk reduction is 3.3%. So addition of 10 milligram of empagliflozin in the patients of heart failure with preserved ejection fraction is again showing huge dividends available to us as clinicians. Interestingly, SGLT2 inhibitor empagliflozin was beneficial to males and females both. Every forest plot is on the correct side of the unity line. Every subgroup was benefited, including females and males both. And we remember sacubitril valsartan combination, that is the ARNI therapy, was not efficacious for males in Paragon heart failure preserved trial. This is also a known fact which you have to keep in mind. Interestingly, you can see the demographics of the patients who have entered the Emperor Preserved trial. You can clearly see that RASI or ARNI therapy or MRA and beta blockers and statin therapy was being taken by patients more than 80% in most of the cases. So a huge benefit, irrespective of all these drugs, which are known beneficial for heart failure with reduced ejection fraction, but they were not being used here for heart failure. They were being used for other reasons in this particular group of patients. But 80% of them were already taking these therapies, and the results were available beyond the existence of these therapies in the background. So when it comes to functional scoring, quality of life improvement, empagliflozin was seen to be superior in Emperor Preserved trial. Not only this, when you compare with all other trials which have been undertaken with heart failure with preserved ejection fraction, you can clearly see that distinctly superior results have been achieved with empagliflozin 10 milligram standard dose versus placebo being added to these background therapies available in all these patients. And when it comes to dapagliflozin also, the data from the delivered trial are not fully out, but whatever noise is coming out is very, very positive. It is music to the ears of every clinician. And dapagliflozin 10 milligrams in preserved ejection fraction has shown to improve the quality of life and the 6-minute walking distance and physical functional capacities of the patient. Again, a trial which is going in a very positive direction, and the results will be out in 2022 very soon. So with the Emperor Preserved now being added to the chart of SGLT2 inhibitor trials in heart failure, you can see how impressive the forest plots are. Everything is showing benefit right from trial 1 to trial 10, and this is absolutely bang on the point, which cannot be ignored, cannot be uh, left as such unless you include these compounds in your medical treatment. You are not doing enough justice to your patients. Now coming to the Amplitude O trial, which has been recently reported August this year only by Navid Sattar's group, wherein FP-glinatide, a GLP-1 analog, which is exendin based analog but is weekly preparation, was added to the patients, and it was found that patients who were taking SGLT2 inhibitors in the background or who were taking metformin in the background both still benefited with the addition of FP-glinatide in this particular trial, Amplitude O. And when it comes to now final chart of GLP-1 analogs after the addition of Amplitude O results, you can clearly see that after Harmony, that was with the LB glutide, which was withdrawn from the market because company found it is it not to be not as a viable compound which can be marketed because of the heavy cost involvement. So after that, this is the first salt which has again shown that how GLP-1 analogs are all helpful as far as the heart failure is concerned, but not as great as SGLT2 inhibitors. But we should not forget again that 35 to 40% contribution to the heart failure pathophysiology comes from the ischemic causes. So when it comes to guidelines for the treatment of patients of heart failure and diabetes, you can clearly see that all the five liflozins, CANA, DAPA, EMPA, ER2, and SOTA are recommended in patients with type 2 diabetes at high risk of CV events to reduce hospitalization for heart failure, major CV events, and stage renal dysfunction and CV death. Recommendation level is 1A, top level recommendation, because more than one randomized controlled trials are available. And when it comes to SGLT2 inhibitors, these three, DAPA, EMPA, and SOTA, are recommended in patients with type 2 diabetes with heart failure with reduced ejection fraction to reduce hospitalization and CV death. Again, level 1A recommendations, and recommendation strongly against TZDs and DPP4 inhibitors continues. Needless to say that hypertension management, statin for lipid and cardiovascular and coronary artery risk reduction, and use of SGLT2 inhibitors, anti-smoking drive, and lifestyle modification, weight reduction, etc., alcohol abuse reduction remains all class 1 recommendation with level A most of the times. Now, coming to this Anna Noramer's commentary, which was presented after the Emperor Preserved trial, she said that if there is no prescription of SGLT2 inhibitor for a particular patient, we should be asking rather why it not has been written, because there are now several scientific reasons to treat type 2 diabetes with SGLT2 inhibitors, and very few reasons not to include these therapies as anti-diabetic therapies in every diabetic patient. We'll clearly know after UKPDS trial and the long-term follow-up of this trial that intensive treatment always pays dividends in the long run. We know that if you don't treat them early and aggressively, you carry a bad metabolic memory. This was proven with the VADT trial and other trials also. Then you also know that even in the negative trials like advanced VADT accord, where cardiovascular benefits were not there for the entire group, but all those patients who were having macrovascular complications when they entered the trial, they were treated intensively in these trials. They all were benefited. So glycemic control, even in the advanced stage of diabetes, if you are having macrovascular complication in the background, it still is beneficial. So diabetes control can never be ignored. And we also know that diabetes control right from the beginning, when done with combination of treatments, has got cumulative benefits, has got longer duration of efficacy, more efficacious, less failures, more patients being covered with euglycemia, more percentage of patients reaching the euglycemia, lesser up titration of other therapies or other anti-diabetic medicines, etc. So many things have already been proven with the publications like verified trial, which support strongly the combination therapy right from the beginning. And this Lancet edition says everything about this, that let people fight about the position of metformin or this or that, but sooner than later every patient of diabetes is going to receive a combination of therapies. So why not right from the beginning? And this very interesting slide, which I have taken from Antonio Cerelio's lecture, who said that why can't we think of merging cardiocentric and glucocentric approach right from the beginning in our high risk patients for high cardiovascular risk right from the beginning? Why can't we think of metformin being added to GLP-1 receptor analogs or SGLT2 inhibitor analogs or metformin therapy combined right from the beginning? Because For all other patients, you can have a glucocentric view, but you should have a strongly combined cardiocentric and glucocentric view for every patient who is at high cardiovascular risk. And this is how multiple targets of etiopathological imbalances can be corrected by such a combination right from the beginning. So this will be the most crucial first step towards optimization of diabetes therapy in 2021, which I will propose must be given to every patient of diabetes in your clinics. So keep in mind these three drugs to begin with: SGLT2 inhibitor, GLP-1 receptor analogs, and metformin therapy. You can choose any one side or any two of these three therapies as your base of therapy, but should be in the combination right from the beginning. This Mad Angle snacks advertisement comes to my mind every time I think of such things when three angles are available. So you can see that you can have a GLP-1 receptor analog or SGLT2 inhibitor or SGLT2 with metformin or metformin with GLP-1. All the three sides are efficacious and as lucrative in terms of clinical results in immediate and the long term both, and overall cardiorenal and cardiovascular protection of your patients of diabetes, including all the benefits of durability, etc., efficacy and safety, etc. And you can clearly see there is no risk involvement of hypoglycemia or weight gain in any of these three possible combinations here. So in diabetes, it is mandatory that cardiovascular protection is accompanied by an early intensive management of hyperglycemia. It has to be done because every passing year, when you are missing the target of achieving euglycemia, you are exposing the patient to the higher cardiovascular risk. For example, if not done in the first year or second year, the risk of myocardial infarction goes up to 60%, 50% up. A Kamlesh Kunti's recent article again highlights this particular fact. So it will be very unintelligent to me if after knowing all these facts we are not doing adequate justice while planning our therapies for our patients. It will be absolutely, I will say, it is criminal to me. So it is mandatory that cardiovascular protection is accompanied by an early intensive management of hyperglycemia. Harmonize the gluco and cardiocentric approach right from the beginning, from day one. An early combination of hypoglycemic agents is the logical solution as far as the diabetes management is concerned. And if you really further want to justify your practice, if you want to further justify the cost involvement available with linked with the GLP-1 receptor analogs, you can always classify your patients with the risk of heart failure and risk of cardiovascular disease, which I have told you in the middle deck of slides, wherein we pointed out how to diagnose high risk patients of diabetes who are definitely at high risk for cardiovascular events. So a paradigm shift now is mandated. New roadmaps are available to us, are clearly visible, and we must be revisiting our strategy for diabetes prevention and diabetes treatment, how to recognize, how to define, let us relearn and reorganize the things. Clinical phenotyping with ECO and NT-proBNP is a step towards precision medicine. This will be the true individualization, a scientific individualization of therapy, early intervention with right evidence-based drugs. Best prevention can be done with then attention to comorbid risk enhancers, as I told you, all those anemia, COPD, sleep apnea, early tight glycemia correction, best combination of glucocentric and cardiocentric drugs with that triangle in your mind, and precautions of hypovolemia, hypokalemia, etc., hyperkalemia, etc., with adverse effects, other adverse effects of with each class of drugs cannot be, should not be ignored. So diabetes is one of the most potent predictors of heart failure and increases the risk of developing heart failure and worse survival outcomes. Diabetes can lead to heart failure through both atherosclerotic mediated and atherosclerotic independent mechanisms. Left ventricular dysfunction is an early complication of diabetes. Earlier diagnosis and management of symptomatic Left ventricular disease and diabetic cardiomyopathy may be an important strategy for preventing the progression to clinically manifest heart failure. Measurement of natriuretic peptides and echocardiography have key roles in the diagnosis and stratifying the patients. Recent studies like Emperor Preserved gives us new hope in treating patients of HFpEF, and metformin remains to be a safe drug choice in heart failure. It is not recommended in patients with CKD stage 4 or severe hepatic involvement. We have to keep in mind the lactic acidosis. If insulin is needed in a patient of heart failure, the patient should be monitored for evidence of worsening heart failure, because salt and water retention is very real problem with higher doses of insulin, especially faster acting insulins, and TZDs are not recommended in patients of heart failure. You have to be cautious with DPP4 inhibitors also. Sexagliptin has clearly been tainted with the trial, and of course the sevortimig in the trial. The most GLP-1 receptor agonists did not reduce the risk of heart failure, except FP-glinatide and LB-glutide. Now I will be adding FP-glinatide here, but then keep in mind the cardiovascular benefits from other routes available with SGLT1 receptor analogs. So SGLT2 inhibitors were shown to be consistently reduce the risk of hospitalization from heart failure in type 2 diabetes, and recommended in type 2 diabetes with at risk from heart failure. And as I told you, at risk from heart failure stage A is absolutely can be applicable for every patient of diabetes. Starts with stage A. Let us not forget that. Presence of diabetes makes you stage A, makes you at risk. So again, remember Anna Noramer's slide. If there is no SGLT2 inhibitor in the prescription, try to ask why it is not there. So with this, a big thank you. Any questions are welcome. I would be happy to answer them, but the Gmail should be precise and should be, to the point. That is my only request. Many answers you can get from my delhidiabetes.com, my website, and I keep on uh, stating small beneficial bits on diabetes, bites on diabetes for my patients, for my readers, for my fellow doctors on Twitter, Facebook, and YouTube. Try to follow me there if you can. If you have a spare time, even 10 minutes a day, try to join my pages. I will love to see you there. Thank you very much. Bye bye.